minutes, just finishing up some technical things on this end, and then we'll get started.
Oh, okay.
Okay, hi everybody. Sorry for that little glitch. Welcome to the Accountable Communities of Health and Value-Based Purchasing webinar. We're going to go around and do introductions in the room and then get started. So this is Kayla Down. I'm on the Accountable Community of Health team here at the Healthcare Authority.
And Chase Napier, also on the ACH team.
Gary Swan, Healthcare Authority, working on Payment Model 2 and Counter to Value.
JD Fisher, also at the Healthcare Authority. I'm working on the payment redesign team for models 3 and 4.
Hi, I'm Mark Province. I'm part of the HCA team in Medicaid transformation.
Great. Thanks everybody for joining. Just so you are all aware, we are recording this webinar and we'll post the link under the resources tab on the Healthcare Authority Healthier Washington website. We can also follow up with an email with the recording link embedded in it, so just so you know. If there are questions throughout the presentation, we have you all muted right now. If you could just enter those questions into the comments pane, we'll be monitoring and can raise them as appropriate. So the purpose of today's webinar is to familiarize ACH partners with the value-based purchasing strategies under Healthier Washington and prompt our collective thoughts around the linkages between ACHs and the payment redesign models. So during this webinar, we will discuss what value-based purchasing is, give an overview of Healthier Washington's payment models, and how this intersects with ACH development, partnerships, and priorities. So we're going to transition over to Mark now, who is going to go over high level what we mean by the paying for value strategy.
Great, thanks Kayla. Actually, if you can move to the next slide. So I wanted to give just a little bit of background as context for how we're looking at value-based purchasing at HCA, and it's probably appropriate to start with something that you're all very familiar with, and that's the current and predominant method of reimbursement, which is fee-for-service. And of course, one of the challenges that fee-for-service reimbursement raises is that it rewards for volume, but not necessarily for value. And as the box at the top of this slide indicates, it's really just a matter of the number of services times the fee for service, which then drives the cost. And it's of course the accumulation of all of those fees and all of those services that continues to cause a rise in costs without necessarily attaching to a measure of outcome or value. So one of the unfortunate results of this is that it tends to leave costs a bit unchecked. I think according to 2014 estimates, national healthcare spending is about $3 trillion right now, and that's about 17.5% of the GDP. So that's a fairly significant investment. And of course, the question among purchasers increasingly is, what are we getting for the investment that we're making? The slide really just indicates that another feature of the fee-for-service system is that services do tend to be often quite siloed, so that there is not necessarily a connection between services received in one setting by a given patient and services received in another setting. Efforts, of course, are underway to try to connect those electronically with electronic records, for example. But again, each provider or set of providers in each of these buckets, if you will, is under a fee-for-service system, unfortunately under an incentive to make sure that volumes are sufficient to bring in the revenue that's required. So without belaboring that any further, obviously that's the starting point, and that illustrates some of the challenges we're seeking to overcome in value-based purchasing. So if you can go to the next slide. In value-based purchasing, really the equation shifts somewhat, and this may not be a precise mathematical model, but the illustration here is that you want the ratio of the outcomes of the care relative to the cost of care to be positive. In other words, you want to maximize the amount of outcome for the cost investment you're making. And it's really the misalignment of cost and quality that have caused us to really try to bring those two things together. In the sweet spot, the intersection here obviously is displayed as value-based purchasing. The idea is not just to measure quality, although that's clearly an essential component, but it's really to provide the information through the measurement of quality back to the providers of service, so that there's some sense of how a given provider is performing relative to expectations. On the cost side, a lot of the emphasis, as we'll see in a moment, is also getting away from reimbursement on a per-service basis and looking at ways to create better financial incentives that result ultimately in rewards for providing better quality care. So that, between these two slides, that kind of represents the origin and the destination. The next slide gives a little bit of a sense of the steps along the way. Some of you may be familiar with this slide. It comes from the Healthcare Payment Learning and Action Network, or HCP LAN. And you'll see at the bottom of the slide there's a reference to the source of this document, which, if you haven't seen it, I'd recommend reading it. There's a lot on this site about value-based payment, and in fact there's a very good paper that you can get through this site titled Alternative Payment, I think Alternative Payment Model, or APM Framework. But these categories, and this slide is receiving a lot of attention among purchasers nationwide, these categories really represent a viewpoint certainly expressed by CMS, the Centers for Medicare and Medicaid Services, and takes us from that current state, if you will, the fee-for-service state, which is Category 1 on the left-hand side, all the way through to population-based payment on the right-hand side. Category 1 we've really already talked about in terms of reimbursement on a per episode basis. Category 2 starts to move away from that. It still focuses on fee-for-service reimbursement in terms of reimbursement per activity, but begins to introduce some additional incentives or payments for investing in infrastructure. So you might have this category a relationship in which a provider receives some compensation for introducing alternative levels of service into the setting. So, for example, the use of non-MD personnel in primary care settings as an example of a type of infrastructure investment, at least in workforce. Other infrastructure investments, of course, involve those having to do with information systems and the like. You'll see a reference, and this category is really broken down into 4 sub-buckets, if you will. Reference to pay for reporting, which is, again, providing financial returns for participation in a reporting system that begins to let the purchasers know the outcomes of the services that the providers providing to patients. That moves to rewards for performance. So again, it's not just, at that stage, it's not just reporting, but it's also how well did you do, and can you get some additional reward for performing well relative to benchmarks. And then finally, rewards and penalties for performance. So there might be not only a reward for doing well relative to your peers or relative to expectations, but perhaps a payback of some kind or a penalty for failure to perform or to increase your performance against standards. Category 3 moves along and really begins to introduce, as item A there indicates, alternative payment models with upside gain sharing, and in B, upside gain sharing and downside risk. An example of payment under this category might be payments for episodes of care. So the idea is not just emphasis on the service provided to a given patient in a given visit, but management of a bundle of services related to the care, say, of a diabetic patient, and management of costs and outcomes within that kind of a bundled approach. You might have in this category, for example, contracts having to do with targeted payments and outcomes for hip replacement or back surgery. So again, it's moving away even further from that payment per service, and really introducing more payment, both payment that gives some flexibility for the provider to use the funds, but also payment in exchange for targeted outcomes. And then finally, category 4 really moves all the way to population-based payment, where reimbursement is related to all of the services rendered to a particular population of patients, which in one sense maximizes the amount of flexibility that the provider has in terms of the use of funds, but also maximizes the accountability that the provider has, or the provider system has, for an entire population of patients. A common theme, as you probably have surmised or already know, in these latter payment models is the need to establish measures and report on those measures so that both the purchaser and the provider can monitor performance against expectations. So the result in the next slide, the intended result of introduction of these models is not just the management of costs, but it really is the provision of better care for patients and for populations of individuals. And you can see in the contrast between the items on the right-hand side of the screen and the items on the left-hand side of the screen, kind of elements of what that movement represents. So moving from fragmented clinical and financial approaches to care delivery in those silos that are illustrated above, to more integrated systems that deliver whole person care. As an aside, and something we'll get to in a moment, you're probably all, or many of you, are familiar with the kind of, or with the emphasis that we're placing right now on integration of behavioral and physical health services, for example. Similarly, movement from uncoordinated care and transitions between providers to more coordinated care. Unengaged members left out of their own healthcare decisions, especially if the providers in the systems, or if the providers of care that they're receiving are not necessarily communicating with one another or not providing meaningful feedback to the patient, and moving instead to more engaged and activated members with connections to care. You'll see some of these incentives, especially in some of the modeling, I think, that JD will talk about a little bit later. And movement finally in where variation in delivery system performance has no ties to clinical or financial accountability and transparency. Movement away from that kind of unmanaged, if you will, variation, more to standardized performance measurement, and more, hence more transparency and accountability. So with that as backdrop, what's HCA doing? In the next slide, you'll see that we've really taken a step as a first mover and a market convener. As many of you may know, the Healthcare Authority purchases care for about 1.8 million Medicaid clients and about 200,000 public employees for a total of 2 million people and their families in the state of Washington. Or, as the illustration indicates, 1 in 3 non-Medicare individuals in the state. Hence, we're the largest purchaser in Washington and in a position to not only directly affect expenditures for care in the state, but also exert some influence as a major purchaser in our relationships with providers and in our communications with other purchasers, both public and private, in Washington. So the goal is a pretty ambitious one, as it's stated in this slide, to move 80% of state-financed health care, and through that influence, 50% of the commercial market to value-based payments within 5 years. And I believe that 5 years goes to 2019, so that's coming up fairly soon. We've already, as you'll hear, made some initial and important steps in that direction, but we obviously have a ways to go. And we're doing that both as a result of direction from Governor Inslee, as well as direction from our state legislature. There's a reference here to Substitute House Bill 2572, which includes language about increasing the use of value-based contracting for Medicaid and public employee purchasing. So that's the path that we're on. So with that as background, we wanted to, in the next slide, as the next slide indicates, talk about 4 payment test models that are part of our SIM grant from the Centers for Medicare and Medicaid Innovation. And we wanted to talk a little bit about each of these 4 models and then clearly talk about how these models affect and benefit from the relationships that we have with ACHs. So I'm going to take the first, which is physical and behavioral health integration. This really results, again, from initiatives from the governor and from the legislature. As you'll see, going back to 2013, a statement from the governor about a vision of full integration of mental health, chemical dependency, and physical health care to improve health, advance care quality, and control costs. And likewise, from Senate Bill 6312, a mandate to integrate physical health, mental health, and chemical dependency in a managed healthcare system for Medicaid clients by 2020. Some of you will know that latter one more by the term early adopter, and which is the name we've given to the program in which Southwest Washington is now participating as really the first region of the state to adopt this fully integrated care model. But the idea behind both of these statements clearly is to integrate in a single model, again, both the financial and the care organization components that make it possible to receive, for a patient to receive care that's really more whole person care. You know, we used to joke in the old capitation days about a decapitation plan which separates the head from the rest of the body, because at the time it seems like we weren't covering, and by we I mean purchasers in general, weren't covering mental health services or dental or vision or hearing, and this is our effort now to reintegrate the body, if you will, and for patients to really combine care for physical and behavioral health services, especially recognizing the clear interdependence between those two and the effect that the separation of those two can have on the ability of patients to be healthy. So the next slide illustrates kind of the path that we're on. So as indicated in the previous slide, we're on a path toward 2020, at which point we expect for every single region in the state to have fully integrated managed care. What that means is the delivery of physical and behavioral health services in one package through our contracts with managed care organizations under Medicaid. As I mentioned, we started on that path. In fact, we're starting 1 week from now. That's the effective date in Southwest Washington of 2 managed care contracts with Community Health Plan of Washington and Molina, in which those services and the payment for those services will be fully integrated. There is a separate contract that runs parallel to those managed care contracts that provides crisis services for not just Medicaid patients, but for other patients in the region as well. In the remainder of the state, right now, effective April 1, we will have BHOs, or behavioral health organizations. Those will operate in parallel with our Apple Health managed care plans, delivering behavioral health services in a prepaid manner, but as I say, operating alongside the MCOs. There are requirements for communication between the MCOs and the BHOs. We are applying measures for performance with respect to behavioral health outcomes in our managed care contracts, and also in the expectations with regard to how the BHOs will perform. You may also be aware that we recently released an announcement that would allow for other regions to come on board sooner than 2020. We sometimes refer to these as mid-adopters. The first such opportunity would be in July of 2017. And for regions that are interested in moving ahead with that, we'll be expecting non-binding letters of intent from those regions in May. So no sooner do we start in Southwest Washington than we turn our attention to the possibility of introducing this integrated care to other regions. And then I think finally, my last slide in this section is just a reminder of where our regional service areas are, which really form the basis for this integrated care purchasing. You'll see Southwest Washington. At present, our managed care contracts, our integrated managed care contracts, are for Skamania and Clark counties. Klickitat chose to remain attached to the Greater Columbia region for purposes of early adopter, but is really has the ability to rejoin the Southwest Washington region later on. But you'll obviously be familiar with this map because the purchasing areas and the ACH boundaries are meant to coincide. So I think with that, I will hand the audio back, I think, to Gary to continue our discussion of the payment models.
Hi, thanks, Mark. So I work on payment model 2, encounter to value, encapsulates federally qualified health centers, rural health clinics, and critical access hospitals. And really with this payment model, we're trying to move federally qualified health centers, FQHCs, and rural health clinics, RHCs, to a value-based alternative payment methodology, and seeking to support critical access hospitals to meet changing community needs, and really begin to move them along the continuum of value-based readiness. So with FQHCs and RHCs, I'd like to frame up the conversation a little bit with a little bit of background around what FQHCs are, FQHCs and RHCs are, and who they serve. So FQHCs and RHCs serve a specific set of population, and due to that, they are guaranteed certain type of payment as mandated by the feds. So FQHCs serve a specific set of underprivileged or underserved Medicaid population. Rural health clinics, as their name denotes, that they are primarily in rural regions and serve rural populations. So really these are the primary care backbone for Washington State for Medicaid beneficiaries. Payment for FQHCs and RHCs is a little bit cumbersome, and I'll try to quickly step through how payment currently exists and why we're trying to transform from this current system to a new system. Currently, managed care organizations receive a premium payment, so payment for all primary care in their managed care contracts, their Apple Health contracts. So this gets paid, spread out not only to FQHCs and RHCs, but all primary care. On top of that, HCA makes an enhancement payment for this subset of providers, FQHCs and RHCs, to bring them up to what's called an alternative payment model, alternative payment level for ensuring that we're providing enough financing to guarantee services for Medicaid beneficiaries. So stepping down a level from the MCOs, the premium payment, or the payment that's built into the Apple Health contract exists in many different current forms, or various forms with FQHCs and RHCs. And the enhancement payment is simply a pass-through to the FQHCs and RHCs. So because of this cumbersome process, because we have these two different payments at two different levels, it results in a reconciliation process. So as our obligation to CMS, it's our requirement to ensure that these facilities are made whole at the end of the day, hence the reconciliation process. So what we're really trying to do is move away from this cost-based system and shift to something that simplifies the reconciliation process and really incents to paying for value. So with the current payment structure, payment is based on an encounter. So you don't get paid unless you meet a certain set of standards and billable standards designated by the feds for qualifying for payment. What we're trying to do is shift to pay for value and get away from the encounter-based system and really move towards a value-based system where we can incent for quality performance, bend the cost curve, and really provide increased financial flexibility. So because of the encounter-driven nature of this service, providers cannot or not are incentivized to provide such things as group visits, telemedicine, nurse home care, non-traditional workforce, and so on. So we're currently in the process of stepping through with stakeholders and negotiating what the new alternative payment methodology will look like for Washington State, and begin to shape around those principles that I've outlined. For critical access hospitals, there are 39 critical access hospitals within Washington State. We are working with a subset of those 39 critical access hospitals that are most vulnerable and vulnerable to closure due to financial stress. So this subset of critical access hospitals has an average inpatient daily census of somewhere between 1 and 2, meaning that their inpatient beds are generally not full. So we're looking to identify service delivery mix that meets community needs and helps to build a payment structure around that service delivery mix that helps to build sustainability for the subset of critical access hospitals.
All right, thanks, Gary. And this is JD again, and I am the analyst for Models 3 and 4. And so we'll start with talking about Model 3, which is largely built around our Accountable Care program that is a new benefit offering through our Public Employee Benefits program. And this began early or late in 2014 conceptually, and last June of 2015 we successfully executed contracts with 2 clinically integrated networks with the goal of improving the patient experience, providing integrated head and body care, and ensuring that the networks assume financial accountability for a defined patient population. These 2 networks, the first, or one led by Virginia Mason, termed Puget Sound High Value Network, and the second, UW Medicine Accountable Care Network, led by University of Washington, have agreed or did agree to provide accountable care in the Puget Sound region, which is comprised of the 5 counties of Snohomish, King, Pierce, Thurston, and Kitsap. Our first open enrollment period was last fall, and we were very pleased with the results, and we came away with over 10,000 total enrollees in the 5-county region. And now the work begins to expand these networks statewide to recruit additional providers in each network and ensure that we can provide this benefit structure and accountable care to all our employees across the state. And next slide, please. And this accountable care program has 5 key components that it's structured on, and none of which, this isn't a hierarchy, but they're all equally important. First, we'll start with the shared risk component. Each network has assumed a 2-sided risk model based on a financial trend over multiple years, and for achieving targets on 19 quality measures that we selected from the statewide common measure set. Next, they're responsible for member experience, and this is largely based on those quality measures. Four of the 19 are focused on patient experience, and each network has agreed to change their infrastructure to support extended hours, including longer weekday evenings and extended weekend hours for primary care, and also building out a special phone number that members can access 24 hours a day. The next component is care transformation, and each network has agreed to provide evidence-based care that largely centers around recommendations from the BRE Collaborative. They've also agreed to achieve primary care medical home level 3 standards and implement shared decision-making pilots. Almost as importantly, we realize that timely access to data of their patient population is a critical component to these networks accomplishing these goals that we've set out for them. And to do so, we are committed to sharing medical and pharmacy data on a daily basis and monthly claims feeds so that they can integrate that data into their provider workflows and have a better sense of how their patient population is looking. And lastly, we also need to ensure that our members understand what is being provided to them and understand what these networks can provide to them. And so we've structured the benefit design to be uniquely attractive to them. The benefit or the premium for this plan, which we call UMP Plus, is 30% lower than the UMP Classic plan, which is our most popular plan administered by our TPA. We also ensure that 100% of services that are preventive in nature are covered in-network primary care office visits, and that there's no medical deductible for individuals that complete a wellness plan. And if we move to the next slide, now we're going to talk about our payment model test 4, which we term the Greater Washington Multi-Payer. This payment model is much more in the development phase, but we're trying to address the problem that we realize where providers lacking sufficient data to manage their entire patient population are unable to move into a value-based payment arrangement. And to address this, we, in conversations with other states who have taken on similar initiatives and have experience in multi-payer initiatives, we realize it's important to drive change through a market champion. So we're constructing a plan to leverage a market champion who has the experience and the leadership capability to convene payer and provider partners, each with a common interest in advancing value-based payments. We believe this approach will enhance providers' ability to manage a patient population and integrate critical population-wide data into their workflows. And as a state, we're committed to providing resources and attributable claims and encounter data to this market champion in order to accomplish this goal. And as I said, it's still in the development process, and we hope to make some significant gains in this later this spring, and hopefully have something in place in the middle of the summer or in the fall.
Awesome. Thanks, Gary, JD, and Mark, for that overview. I just want to open it up for questions on the payment models, if there are any. If not, we will move ahead to the intersection of ACHs and value-based purchasing.
We're asking that you please respond via chat if you have any questions. Thank you.
Maybe we just did such a good job explaining there are no questions. So the remainder of today's presentation will focus on the potential linkages for ACHs and the value-based purchasing strategies under Healthier Washington that you just heard an overview of. So this is a slide that everyone has probably seen a few times with the follow-on that Healthier Washington is grounded in the understanding that health is just more than healthcare. This graphic represents that the 20% of factors that influence health are those clinical factors, with the 80% being socioeconomic, health behavior related, and physical environment. So while we recognize that and the understanding that improving people's health outcomes and lowering costs depends on addressing those factors and linking supports for them within the healthcare delivery system, we in turn say the ACH represents all aspects of health within the community, not just the 80%. The ACH value-based purchasing linkage is the opportunity to better inform and align the entire system. So thinking back to the continuum of value-based purchasing graphic that you saw a few slides ago, within health systems transformation, ACH partnerships help accelerate the move from a non-linked quality and value system to the ultimate realization of population-based purchasing at the local level. And while we don't know the exact clarity of those relationships and models yet, this conversation today is a good starting point.
So we put this map together, and this map crosswalks all of the payment models with the ACH regions. And really the purpose of this is to show potential impacts over the longer term for what the payment models might, where they might impact. So currently, stepping through the legend, Payment Model 1 Early Adopter, starting on April 1, will affect Southwest Washington Regional Health Alliance and is set for Skamania and Clark counties. Payment Model 3, denoted by the green border, is for impacts Snohomish, King, Pierce, Thurston, and Kitsap counties. So those two payment models, starting on April 1 with Payment Model 3, or Payment Model 1, and Payment Model 3 starting in January actually of this year, are in place and are something to consider for your ACH regions. Payment Model 2, as you noted before, there's really two different payment models that will be piloted under Payment Model 2, one addressing critical access hospitals and one addressing federally qualified health centers and rural health clinics. So right now we're still in the development phase and discussing what an alternative payment methodology is going to look like for FQHCs and RHCs, and what a payment and delivery system is going to look like for this subset of critical access hospitals. But this gives you an overview, or gives you a general picture of where the FQHCs and RHCs sit within Washington State and some of the potential pilot sites. On the longer term, as has been mentioned throughout the webinar, these payment models are going to be spread across Washington State in the coming years and through 2020. So I think it's helpful to look at this and in the context of what's happening now and what planning you might want to think about going into the future. Also, it's important to note that payment model 4 is not yet on this map, as it's still in the early stages of development, and we're working on negotiations for moving that forward. This slide here really is meant to draw the conversation out from the specific payment models and get you thinking about the potential impacts, broader impacts for value-based purchasing across the ACH regions. So looking across each of these pie charts, we've identified commercial and public other, Medicaid, Medicare, and uninsured populations. Now this is a rough estimation, and by no means is something that you would want to send out in published literature for use of your negotiations, but it gives us a good bearing, or at least a bearing, to begin conversations and start thinking about how we want to discuss value-based purchasing within your region. So take, for example, King, commercial and public other accounts for almost 60% of the insured within King County. Medicaid accounts for 21%, Medicare 13%, and uninsured 7%. As compared with North Central, where commercial and public other are much smaller, and you have a much larger Medicaid and uninsured population. So it gives you a frame of reference on where you might want to head in terms of how you're thinking about value-based purchasing, and really who you might want to start inviting to the table should these conversations arise.
Great, thanks. So I won't read all the questions that are on this slide, but mainly this is just level setting for some of the questions that we're processing at the state level, and they likely mirror similar questions that you have had around the ACH table in your regional forum. So we always welcome your assistance in answering these, and I think in order to answer them, we need to collectively identify how value-based purchasing can be aligned with and advanced through scale and spread the regional priorities and projects of the ACHs, which includes data-driven decisions at all levels. We also need to think about the existing gaps in partnerships that may exist at the ACH table, and not to forget about the 20%, the health systems partners, that may need to be identified to help move closer to value-based purchasing at a regional level. We recognize that ACHs are the convener of these key community partnerships, which in turn share best practices and lessons learned. And ACHs are a feedback mechanism and early warning system for the state. To that last question on the screen, how can we collectively use data to incentivize progress along the value-based continuum? It's something that we all need to map out together. So we open it up now to any questions on any of the slides, really, with anybody in the room here or on the phone. You have Mark, Gary, JD, Chase, and myself, Kayla. If not, we would be happy to answer questions offline. Our contact information is on this slide. We will also send out a recording of this webinar and look forward to touching base soon. So we'll leave it open for questions for the next few minutes, and if not, hope everyone has a great weekend.
Well, if there are no questions, I would like to make one last plug. We have developed and are set to release a Paying for Value survey that will be released very shortly. And we are primarily targeting providers and payers, but an aggregated set of responses will be released and made public once we've finished compiling all the responses, which I'm sure will be a few months out. But stay tuned for that if you're interested. I'm sure it'll have a lot of information that will be useful as we make this journey together.
Okay, it looks like we don't have any questions. Hope everybody has a great weekend. Thanks for joining the webinar today.